We don't have any kind of education about menopause for so many women who just don't know what's happening to them, especially to their brains and their minds. So there's this kind of black box in our education, medical education, scientific education. So many women report,
I don't sleep.
Oh my gosh, yes, absolutely. Not being able to sleep through the night, which also will impact your mental health eventually, right? But the first reaction is just stress. Menopause is almost like an activator. It kind of unmasks potential medical vulnerabilities. The symptoms are not your destiny. There are remedies. There are things that we can all do to feel better.
Métamorphose, le podcast qui éveille la conscience.
What if menopause wasn't just a matter of hormones, but primarily a matter of the brain? Why do so many women who reach menopause suddenly feel anxious, tired, or lost without understanding what is happening to them? You are not crazy, say my guest, who is a neuroscientist, an expert in nuclear medicine, associate professor who specializes in the woman brain. In her latest book, Menopause, published in French by Thierry Souccar Éditions, and the Menopause Brain for the US edition, she deciphers the effects of menopause and perimenopause on women's brain to help them better understand and navigate this period of their lives. Hello, welcome, Lisa Mosconi. I'm so excited to talk with you today on this such important topic. I would say crucial, maybe it's a crucial topic. So welcome in Metamorphose podcast. I'm super happy to meet you, Lisa, today.
Thank you so much for having me. It's such a pleasure to be here. And I'm very happy to have this conversation.
Yeah, I'm sure the French audience will be delighted to hear from you because we need that kind, of course, of information. And you are, Lisa, a pioneer on that topic. Let's start with that. Maybe a lot of women describe midlife as the moment they start asking, am I losing my mind? You state very clearly women are not crazy. From a neuroscientific perspective, what is happening in the brain during menopause? And we will talk about what is really menopause just after that.
Mm-hmm. So we're just starting to learn the many ways that menopause may or may not impact a woman's brain health. What we know mostly comes from clinical studies and observational studies. And what my team and I have also added to the mix is brain imaging. And other scientists as well have been trying to map the impact and the effects of the menopause transition directly on different parameters of brain health. And I think what we and others have found at this point is that menopause is a dynamic neurological transition. And I think that this is very new for so many women to hear because as a society and as women, really, we have been taught that menopause has something to do with the ovaries. We associate menopause with the end of reproductive function and a change in the function of the ovaries. But what women experience most are actually neurological symptoms. They are brain symptoms. They seem to just hit you out of nowhere. And that can lead to fear, to anxiety, to the idea that you may be going crazy, that you may be losing your mind. We have so many of our participants and their patients who come to us because they are sure that they are experiencing early onset dementia. So that's as profound an effect as menopause can have on a woman's mental health and brain health that hasn't really been studied until very, very recently.
Yeah, Yes, we're going to go through that very deeply because it's so important. And sometimes women, as you said, they feel like I might have a disease or a cancer. I don't feel well. As I said, I'm losing my mind. And maybe it's very important to define the menopause from a medical point of view. It's a process. It's not just the fact, the day the period stops.
Yes, one could wish it were that simple. But no, menopause is a very complex neuroendocrine transition that impacts your brain just as much as it impacts the reproductive system and the ovaries. So, from a clinical perspective, menopause is divided into 3 major stages or phases. There's a premenopausal phase. Usually we say it starts after age 35, so when midlife begins, and you still have a regular menstrual cycle. That is the premenopausal phase. What many women will notice is that, however, even though the cycle is regular, it may start changing a little bit. It may be a little bit heavier. It may be a little bit lighter. It could be a little bit shorter, a little bit longer. So there are some variations within the framework of premenopause. Then at some point, usually in the early 40s or mid 40s, the menstrual cycle starts skipping months. So you may go from having a menstrual cycle today to having your next menstrual cycle in 2 months or 3 months from now. And that is the early perimenopausal stage, when your cycle is missing for 1 to 3 months at a time. Then later, you will start skipping more periods. And once your period is missing for, like 3, 4, 5, 6 months at a time, that is the late perimenopausal stage where the symptoms are more likely to be present or more severe. So hot flashes are usually associated with menopause, or night sweats, which also is not necessarily the best term because some women just feel chills. They're not hot, they're cold. And there's this change in the way that the body and the brain really regulates body temperature that's being characterized as the main symptom of menopause that most women are familiar with. But so many other women feel brain fog. Like this idea that you have mental fatigue. Your brain is tired. It takes so much more energy to do something that 3 years before, 5 years before, you would have done like this. Yeah. So that is very upsetting to so many women. And their forgetfulness, there can be forgetfulness, there can be reduced attention span or a reduced ability to multitask. Also, perhaps reduced resilience to stress at that particular phase. Anxiety may be a symptom. Depression may be a symptom. Reduced libido may be a symptom. And they do tend to cluster up together and they intensify at that point of the transition. So not after menopause, but before. Yeah. And that's really important to know because that phase for women who are fairly lucky can last 1 or 2 years, but for some women can last up to 7 years. And that could be very disruptive. And it's important to know. It's important to know that menopause is not just the time where your doctor says you haven't had a menstrual cycle for a year or more, you are now in menopause. Yeah. The most brain active part of menopause is actually prior to that. It's the years leading up to no longer having a menstrual cycle. That is menopause, clinically defined. Yeah. Afterwards, there's the post-menopausal phase that lasts for as long as a woman is on the planet, right? Once you have reached menopause, you are post-menopausal
forever. Yeah.
In the first few years, up to 6 years, are still quite active from a brain perspective. The brain is still adjusting, and the symptoms may persist, but then eventually, hopefully, fade away for many women. And then the rest of the menopausal stage, so the late postmenopausal phase, is typically less turbulent for most women, although for some, unfortunately, the symptoms persist.
Yeah, we'll come back on that regarding also the hormonal treatment later on. But before that, why does menopause exist at all? You treat that question in your book. And what problem is it also solving for the brain in terms of energy, longevity, and resilience?
So that's a really controversial question or topic, if you will. There are two schools of thought at this point. There are scientists and epidemiologists and clinicians who do believe that menopause is a mistake, that nature did not intend for women to live past their reproductive years. But medicine and technological advancements have extended a woman's lifespan in ways that are not necessarily beneficial for her. This is one school of thought. It's not my school of thought, but it's legitimate, and we do need to address those concerns. And that is based on the notion that if you look at all female species on the earth, very few outlive menopause. So most female animals die relatively soon after the end of their reproductive life. There are very few species who do live past menopause. And these are some whales, like killer whales, which I love the analogy, narwhal whales, potentially some type of Asian elephants or giraffes, and possibly a bug, an insect. It's called the Japanese aphid. So, and women. So there's something special about a woman's ability to live past menopause that we should not take for granted, in my opinion. Then there's the other school of thought that takes after the grandmother hypothesis, which is a very interesting hypothesis that says, well, life is not just about reproduction, right? There is enormous value to having your mother and your grandmother being part of your life as a younger woman. Once they are past their own reproductive life, at that point, they're no longer birthing children, but they can switch into a caregiving position. They can help you, younger woman, have children and also nurture the grandchildren and support the species and the tribe in that case, but providing all the caretaking that baby humans need. You know, we're very difficult metabolically, anatomically.
It's a survival process, you said.
Yes. It's not just about you, individual, being able to have more children to pass on your genetics, right? That's Darwin. We're looking at the 1800s. Today, we do understand that there is value in supporting the next generations without necessarily being directly contributing to the next generation. So we're now testing both extremes of the continuum, but I think it's undeniable that societies where women, older women, are present do better than the alternative. So I find that very important. And from a brain perspective, we and others have shown that the human brain, women's brains really, have the ability to adjust to menopause and carry on, whereas other animal species do not have that ability. So that, to me, speaks to evolution. And of course, it's something that we need to study more deeply, but in my opinion, it's very encouraging.
Yeah. In your book, we can see the brain of premenopause and a menopause person in the evolution is in like 3, 4, 5 years. And also you're talking about the difference between the female brain, the woman brain, and the man's brain. There is a difference. Why it is important to see those differences and to understand them. You said that more than 3 women out of 4 develop brain-related symptoms during menopause. It's a lot. And they are frequently, as you said before, minimized, even by women themselves, because they don't. If you are in your 40s, early 40s, you don't think it's a premenopause. You're not in that period. You just maybe had children, or you're just past your 40s. You said, "Wow, now I changed. I'm not in the youngest part of me, maybe of the humanity." But you are not. You are not oriented to think about menopause at that time. So maybe that's why. So we are minimizing the symptoms.
Yes, I feel like we don't receive education as women about our bodies, right? We do understand that at some point in life you go through puberty, right? Likely your mother has told you about it. If she hasn't, your friends have, right? You know that at some point your body will develop and you will become a woman. We also know what happens once you're pregnant. We do have education. We do take, I don't know in France, but here we take classes. When we're pregnant, we have to take courses, right?
Yeah, it's the same in Europe, yeah.
Exactly, that take you through the process until the baby arrives, right? Then you're on your own. There's very little information shared about the postpartum period and how long it takes to really recover from giving birth to another human being. But at least there are resources and people know about it. But we don't have any kind of education about menopause. And that can be extremely destabilizing for so many women who just don't know what's happening to them, especially to their brains and their minds. And the one reason that we don't have this information is that the research has not been done. You know, when we talk about neuroscience, which is my field, so the study of the brain, a lot of information we have comes from animal studies.
Yes.
And most animals don't go through menopause the way we do, or from men, right? And men don't go through menopause at all. So there's this kind of black box in our education, medical education, scientific education, where we have some notion of what menopause may or may not lead to and involve, but we're, I believe, systematically downplaying women's concerns as related to their brain health and mental health around the menopause transition. So many women, I mean, the vast majority of women in their 40s, if you go to your doctor and say, I'm having brain fog, or I don't feel like myself, or I'm having depression, anxiety, some women feel very irritable. Or just so many women report.
Oh, I don't sleep.
Feeling. Oh my gosh, yes, absolutely. Not being able to sleep through the night, which also will impact your mental health eventually, right? No matter how resilient you are.
Of course, yeah.
But the first reaction is just stress, right? From most physicians, many physicians, are you stressed? Are you having a difficult time? How's your marriage? How's your relationship? How's your life? How's your family? And so many women end up being put, at least here, end up being put on antidepressants because physicians do not recognize, in some ways, manifestations of menopause outside of hot flashes. Like if you say, I'm having hot flashes, they'll be like, oh, let's talk about options.
Yeah.
But for everything else, we don't have a good framework yet.
Yeah. And also, I show your book, and I remind the auditors, the audience, that there is now a very good French version of your book.
Yeah.
But just to say that there is also a separation between gynecology and urology that maybe failed women during this life transition, because as you explain, and maybe we go deeper into it, you've been talking about ovaries, but the major problem is how the brain reacts, and it hasn't been studied since very soon.
Yeah. Yes, absolutely. See, in Western medicine, I think we're really good at addressing acute reactions. And there's this paradigm where every organ has a doctor, right? If you have a problem with your heart, you go to the heart doctor. If you have a problem with your eyes, you go to the eye doctor. Menopause is not a disease, it's a transition that, yes, it is triggered by the ovaries, but because the ovaries are connected to the rest of the body and communicate to the rest of the body and the brain using hormones, then the effects are not localized to the ovaries. The effects are systemic, right? Heart functionality can change, metabolic activity can change, fat distribution can change, bone density can change, brain function can change. But menopause has been somewhat confined to the ovaries. Therefore, you go to a gynecologist. Gynecologists do not study the brain, do not manage, in a way, right, brain health. And unfortunately, brain specialists are not trained to manage the ovaries or menopause in the first place. So we do have this disconnect that is now becoming very clear.
Yeah.
And many clinicians, including ourselves, like our clinic at Walcott Medicine, we now use integrative medicine by working with gynecologists. We have a great relationship with our OB-GYN colleagues in the menopause clinic, but we also work with cardiologists, and we work with endocrinologists, and we work with all different specialists, neurologists, obviously, but also psychiatrists, because there are so many aspects to menopause that may need to be managed, where you need more expertise to really look at a woman as a woman, not just ovaries.
Yes, but the women who are listening to us, I'm sure they will say, so who am I supposed to see? What kind of physician? My regular physician, the gynecologist, or a neurophysician? And of course, those specialists, they will say, okay, no, it's not, it's a process. So I don't want to see you for that kind of, problem. So it's difficult to know.
It is difficult to know, but things are changing. I like the notion that our menopause is not our mother's menopause. Right? The new generations have access to so much more support and more specialized care than ever before. And this is not universal yet, but we are moving in that direction. Like here, I think the first thing to do is definitely your gynecologist, because there are things that need to be assessed. I mean, ovarian function needs to be evaluated first. And it's very likely that your gynecologist may be able to counsel you as to whether hormone therapy is appropriate or another type of therapy is appropriate. We have so many more options now therapeutically than ever before. So that would be a great first step. If concerns are severe and they're not alleviated by those kind of therapies, then I think it would be good to see, for instance, a brain specialist, because the brain is an organ that can be impacted, right? So it's good to have an evaluation, especially for women who are really worried about dementia. Like if you have a family history of Alzheimer's disease, if you have genetic markers for Alzheimer's disease, it is again, this is in my opinion, but I do see a lot of value in prevention and preventative evaluations. Come get cognitive testing at a minimum, right? So that we can compare your memory to other people's memories, and then we can reassure you it's menopause, right? It's not something, it's not something more difficult or more severe. I'm not disregarding how intense the symptoms can be, but menopause is more addressable and is more temporary, certainly, than cognitive impairment or cognitive decline down the line, or a stroke. So that's important to know.
Yeah, the problem about what you were talking, severe symptoms, is that often it's not as severe, but it's the fact that we have maybe all those symptoms, like lack of sleep, lack of memory, brain fog, etc., etc. So it's plus, plus, plus. So each one separately maybe not severe, but
it's a lot.
The corpus, it's a lot. You know?
It's a lot.
No more libido, so maybe the couple is not right good at that moment, etc., etc. So at the end, it is severe.
Oh, for sure. That's exactly what I meant. Like, I'm not saying that is not an issue, but it's an issue that can be addressed.
Yeah.
So it's important to know that there are specialists that can help. Whereas for so many years, the idea was, as you go through menopause, you just do it. You're quiet. Just be quiet. Right? There's nobody you can talk to. There's no therapist that you can take. For so many years, women were told, do not even look at hormone therapy unless you want to risk cancer. Right? Whereas now we understand that obviously you want to be careful, but that option is on the table and can really alleviate a lot of issues for a lot of women. I'm not trying to push hormone therapy on anybody. I'm just saying it's an option. Whereas until just a few years ago, the general mindset, it really wasn't.
Yeah.
And now we have other options as well that are not hormonal. So we can work with that. That's something we can work with. And I think it's so important for all women to know that there are things that one can do. And also lifestyle is really important. So it's not just medications and prescriptions. There's also a lifestyle mindset component.
And we are going to talk about it later on. But of course, when we have those symptoms, and sometimes women, especially in perimenopause, they don't put them together. I'm a little depressed. I have anxiety. Maybe my kids are going out the nest, so it's empty nest. So we don't know, and the women, they don't put those symptoms together, and that's also the problem. And the physicians sometimes, as you said, you're stressed or you're tired, you have too much work, you have to, you are in the midlife crisis. But yes, we are in the midlife crisis, but for some hormonal reason. And you're talking about a neurological window at that time that is very important.
Yes, the window of opportunity.
Yes.
So, yes, we are aware that there is a window, like a time window, during which the brain is particularly sensitive to hormonal changes and hormonal fluctuations. For many, many years, the window was considered quite narrow, just a few years before and after the final menstrual period. Whereas now we have done studies, we as a scientific community, we've done studies to show that this window of opportunity for intervention as well is actually wider than we previously thought.
Okay. Yeah.
So it looks like the brain is most responsive to or maybe most responsive to hormonal therapy for years prior and after the final menstrual period. And of course, we need to test this better. But I find that encouraging to know that there is time to address the changes.
What is the link with depression? have you seen women that goes into very deep depression, or if, as we said, it's the corpus of symptoms that goes to depression?
Yes. So I think what's really important to understand is how menopause impacts brain health. So the brain and the ovaries are connected by the neuroendocrine system, and what powers this system is hormones. So estrogen, progesterone, these hormones that the ovaries make flow up inside the brain and communicate information. Estrogen, in particular, is called the master regulator of women's brain health because our brains have a ton of estrogen receptors. So estrogen works like a key that needs to unlock a door. So estrogen is the key, and the estrogen receptor is the lock that needs to open. Once this happens, then a lot of wonderful things can happen, from more blood flow, more energy, more protection, more plasticity, less inflammation, less oxidative stress, but also regulation of function. So that's very important. So there are very specific parts of the brain that respond preferentially to estrogen. They have more of these receptors. Some of these brain regions are important for mood. Some are important for sleep. Some are important for memory. Some are important for attention. So what happens, for instance, there's one part of the brain is called the amygdala that is involved in mood and mood regulation and mood stability. Is not the only one, is one off, but just to clarify how this works, right? So if estrogen is consistent, if the concentration is stable, then the amygdala has stable functionality. If estrogen starts going high and low, or just low, the function of this brain region will change. And that may lead to symptoms of depression or anxiety or fear or even rage in some women.
We knew that very well with the postpartum, for example, because we had a lot of fluctuation of the hormones, for instance. But we didn't think about, we have the same in premenopause. It's doing the same up and down. As you said, it's going up and down. And one of the boss in estrogen is also estradiol, as you said. You said it's the CEO of the brain.
Yes. So estrogen is a class of hormone, not just one hormone. There are different subtypes. And the most powerful, the most neurologically active and most abundant is called 17-beta estradiol, which is the hormone that the ovaries produce the most of until menopause. And it's also the hormone that really has the greatest representation in the brain. So when estradiol is like the CEO of the brain, like I was saying, it's like the master regulator of women's brain health because it's a little bit everywhere, but it's also really strong as a hormone. And so it's like, okay, you need to have more oxygen, you need to have more nutrients, you need to have less inflammation. So it's a little bit everywhere. When estradiol retires, if you will, then another type of estrogen that's called estrone kind of replaces it. But the problem is that our bodies don't make that much estrone, so there's less to start with, and the hormone itself is not as strong. So you basically end up with a backup CEO that is not that good, if you will. And so some functionalities are preserved, obviously, but you do feel that something is amiss. Yeah. That was my way of explaining.
Yes. You're talking really about remodeling of the brain during that process. How does it work? And to give good news, you said also it can be a superpower. When we are suffering hormonally from a lack of estrogen, we don't think it's a superpower. So in which sense the brain is adapting to to the next period? What is going on?
So this also needs to be studied in greater detail, but we do have some evidence, at least, that menopause is like a renovation project on the brain. Because if you think about it, all these neurons that we have that are key to enabling a pregnancy are no longer needed. And neurons take up a huge amount of energy and space. So it makes more sense, and this is my own interpretation that needs to be verified, but in my opinion, again, it makes a lot of sense for the brain to say, I no longer need these neurons. I'm just going to say goodbye. Or not the neurons perhaps, but the connections between neurons. So I'm just going to take my brain and rewire it in a way that is more helpful to you as a woman, now that I no longer need to worry about you having children, raising children, surviving motherhood.
Yeah.
But let's move you forward to the next step of your life that is no longer reproductive, but that needs to remain very productive, right? So we have seen this rewiring happen in puberty.
Yes.
We have seen it in pregnancy. And we do see some of that in menopause. And we just published a study. I'll send it to you. It's very pretty. We have some very pretty images as well for your listeners, if they want to see them, where we show that the connectivity of the brain is very dense at the premenopausal phase, is dramatically less at the perimenopausal stage, which means there's something that's happening that we can't quite capture yet. But then, boom, it kind of comes right back up at the postmenopausal stage, where the brain, where women's brains are actually even more interconnected relative to men's brains of the same exact age.
Yeah.
There's more distributed connectivity. So clearly those brains are wired to get stuff done, right?
Yeah.
But they're wired perhaps differently, because now the brain has different needs. You as a woman, you have different needs, and your brain needs to support that. So that's obviously, I think, an advantage.
Yeah. And it's always the cursor of the suffering. If a woman feels she's suffering, one of the, as you said, one of the options, and we're going to see the other options as well, it could be the hormone replacement therapy, HRT. Given all the fear that, as you said, and confusion around hormone therapy that we had before, now we have another kind of treatment. We're talking as well of the French traitement à la française. We are saying it because we have, we put it on the skin mainly in Europe. And especially in Switzerland and in France. I don't know in the US and in Italy, Dr. Mosconi, you'll tell us. But you said that it's, of course, it's they have to be informed, they have to see that with their doctor and physician, but what would be the consideration for women who are suffering? For you, it's a good option to take that hormonal replacement therapy? Sorry.
I would say the hormone replacement therapy is a viable option for many women. We do have contraindications, which are important to know. Some women are not eligible for hormone therapy. Things are a little bit more flexible over here, although there's heated debate over where to draw the line. And things will certainly change. But right now, professional societies internationally have revised their position.
Yeah, especially the FDA, huh?
Yes.
Very recently,
Yes, that's right, also. But yes, so clinically, clinically, now there's a generalized statement that for most women younger than 60 with active menopausal symptoms, the benefits of hormone therapy outweigh the risks. And the risks are actually considered rare. And I think that this is really important for so many women to hear, because we still have in our collective knowledge and understanding, we still hear the warnings. HRT causes breast cancer, right? So many women will just tell you right away, I don't take it because I'm scared of cancer. So it's important to have a balanced understanding of what the risks and benefits really are. And for instance, I think a lot of women can relate to the notion, and I don't know in France or in Italy, but we do know that drinking too much alcohol is a risk factor for breast cancer.
Yeah.
But it's modest as a risk factor, right?
And the lack of sport as well. Sedentarity is the big risk of cancer, for example.
Absolutely.
Or junk food. Yeah.
Yes. So those risks are actually more impactful than hormone therapy in terms of risk of breast cancer than the type of hormone therapy that was used 20 years ago that was linked to breast cancer risk. Mm-hmm. But I don't hear that many people say, I'm not going to have this glass of wine because I'm worried about breast cancer. Mm-hmm. Right? So it's important to know what the actual risks are and what the context is. And this is not to say that the risk is zero. I'm not saying that. Absolutely. We're not saying that. We're saying the risk is individual. It depends on a number of factors that your physician can help you sort through and then decide whether or not hormone therapy may be a suitable treatment for you. And like you said, there are many different ways to use hormone therapy. You can take a pill, or you can use a patch. Here we do lots of patches. Or you can do the spray or the gel.
Yeah.
It's all individual. It really needs to be individualized. And it's on the table. I think what's important to say is it is an option. It's not for everyone, right? If that doesn't work for you or you don't want to take it, there are other options. And let's talk about the other options as well.
For the brain, what is the good thing with the hormone replacement therapy?
For the brain is a complicated organ. We currently treat symptoms specifically. So hormone therapy is approved for vasomotor symptoms, which are the hot flashes and the night sweats. Yeah. It is used here off-label also for sleep disruption and for mild depressive symptoms when those are triggered by the menopause transition. Obviously, if you can't sleep for other reasons, then hormone therapy won't help you. Mm-hmm. But if your sleep is disrupted because of hormonal changes or the night sweats, right, then hormone therapy obviously may help out. So those are the biggest indications. For brain fog, we're working on it.
Okay, and it prevents also from other disease, like for Alzheimer, it helps, or cardiovascular. There are indications.
Controversial.
Yeah, I know.
Let me tell you, we're working on it. I do feel that there is a role that needs to be clearly researched in ways that are modern and that are unbiased. So this is what we're doing right now. I don't know if you heard, but I just launched what is believed to be the largest ever research program on women's brain health, especially menopause, hormonal changes, reproductive history, and risk of Alzheimer's disease. So it's a 3-year sprint, which means that we have 3 years and a large budget to really answer the most pressing questions. So in 3 years from now, hopefully I'll have specific answers about this. And we're hoping to provide the kind of rigorous data points that we all need as a scientific community to reshape the conversation and hopefully finally move away from something that happened 20 years ago that we're still kind of gonna say stuck with. It's not the best word, but we're still heavily impacted by.
Yeah, let me ask you a kind of tricky question, if I can express it properly. If we take the hormonal therapy, we don't let the brain do the job it's trying to do. It means adapt, as you say, rewired the thing. So, and if we stop the hormonal treatment little by little, we reproduce the premenopausal process, making like fluctuation. And if we stop at 60, the hormonal replacement therapy, at 60, it's like the menopause. It's brutal. So we are doing the same thing again. So I was wondering whether it's a matter of time, and if we're taking the treatment, are we just postponing the symptoms?
No, I don't think so.
Okay.
I think what studies have shown...
Does it make sense to ask you that?
It does make sense, yes.
Yeah.
Yes, absolutely makes sense. And we thought about it too, for sure. And we are now addressing that using brain imaging. So now we finally have some tools that allow us to measure estrogen concentration in the brain. If you can believe it, which I could not, until 2024, we had no way to do that, which is unacceptable. But well, now we do. So we're learning more and more and faster. And what my understanding is that if you take hormone therapy during the progression, during the transition to menopause, that will actually ease out the transition. So because it doesn't necessarily change your brain, but it alleviates the symptoms. So your brain is still going to transition, your body will still transition, but you may not feel it as much. And the idea of taking hormones after menopause for a certain amount of time, that's also been revised. So until a few years ago, the idea was you just take it as little as you can for as short a period as you can. As soon as you're feeling better, you stop. Now the idea is that there is no cutoff. If you have the symptoms, you keep taking it. If it helps you, you keep taking it after age 60. Though, of course, you want to be careful. You want to work with a physician who really understands you and does all the right testing. But there is no arbitrary age by which to stop. And we are using brain scans and other modalities to really map out what happens in the brain hormonally and also with other parameters when you don't take hormone therapy as compared to when you do take hormone therapy. So we're doing the studies now. And let's see. But I would say there is no evidence that taking hormone therapy would hinder the transition process or put you or your brain at a disadvantage. If nothing else, it alleviates the symptoms. I will also say that it's very person by person. Like some women really benefit, some women really don't love it. So we're trying to also understand if we can possibly predict this kind of response. Like what women are more likely to benefit for hormone therapy and what women may not, and why, so that we can better decide once a new person starts treatment, is that right for you or not?
Yeah, it's really interesting because the brain can say, oh, maybe it's a kind of fake it, you know, it's fake. And also, but you respond to that just right now. So it's really interesting. And also, if you take it after maybe 2 years or 5 years, we know that we have a window of 10 years after the period stops. I don't know if it has been revised as well. But the brain suddenly says, oh, my God, it's coming back again. Estrogen are back, or progesterone is back. What's going on? And, you know, it's... and from that perspective, it's better to take it before earlier.
Yes,
so there is not that shock of, oh, what's going on? Well, it's an image, of course. It's a metaphor I'm doing. But
well, it all depends on physiology. See, the thing is, what really matters here is not the hormone per se, but is the receptors. The receptors are not forever. The brain needs to make them constantly.
Okay. All right.
And at some point, if you don't have any hormone to activate the receptor, then the brain is going to think, well, I don't really need them. I'm not going to put the effort to feel these little things. And so at some point, the estrogen receptors are down-regulated, which means they kind of disappear. Once they're gone, you can take all the estrogen you want, but that estrogen will do nothing.
The receptors are gone.
So it's the system that needs to be active. And that's what we're trying to define with this window of opportunity model. How long can I find these estrogen receptors? Are they still working? If they're not stimulated for a long period of time, so that can tell us when to start intervention, when to stop. And also, I would really like to know the appropriate dose for the brain. Because the doses that we're using are specifically to alleviate symptoms. Yeah. But for us, the question is what you were asking before. Well, can I use hormones to support the brain, not just to remove the symptoms or alleviate the symptoms, but can I use them as like a preventative strategy for brain health? So we'll see.
Yeah, exactly. We'll see, because it's quite empiric today. They tell you, okay, you take the minimum dose and you see. And if 3 or 6 months you feel better, well, it works.
Yes,
and if it doesn't, we just
like, it's like a little bit like juggling. Let's see.
And if it doesn't, we increase the dose, or maybe you don't have the receptors anymore, as you said. And can we measure the receptors, or we cannot?
Yes. Yeah. We're starting to be able to do that now. And one thing that's important that I should mention that most people don't know about is that we can measure hormones in blood. Yeah. Right? You can go to the doctor and do a blood test and say, oh, my estrogen is this much. Yeah. That has no relationship with the amount of estrogen in your brain. Those are two separate systems. The brain just handles its own estrogen in different ways. So I cannot use a blood test.
Very clear.
Okay.
Very clear, but good to say it again, because for some people it's we know the estrogens are going.
Like, oh, I went to the doctor and my estrogen is low, therefore. So we don't use blood tests to determine whether a woman is a candidate for hormone therapy. We just use symptoms, because the symptoms come from the brain. And the blood doesn't tell you anything about your brain. Mm-hmm. So I would love to move that to a brain scan.
Maybe quickly, can we talk about progesterone and testo, but very quickly. And after, I want you to move to the lifestyle choices and maybe the non-hormonal options that we could have, because it's so important. Yeah,
absolutely.
So maybe on progesterone and testo, very quickly, if you have something to say about it. I'm sure you have.
So progesterone is another very important hormone that is quite consistently overlooked and tends to bottom out, tends to decline before estrogen does. It's not as well studied, but it's been linked to changes in sleep predominantly. So sometimes progesterone therapy can be used to support specifically sleep, which is important to know. Testosterone is not as well studied in terms of brain health. We do know that testosterone therapy can help with low libido. It's approved for that. We don't fully know if we could also use that kind of therapy to support things like energy or cognition or mood. The studies have just not been done. We need to have more research, more conclusive research. Is that short enough?
Yeah, it's perfect. So good to know. So progesterone, if you want to take progesterone, we just have the pills or by the vaginas. We can take it as well. And mainly at night. Huh?
Yeah. So for sleep, it would be a pill. Usually it's oral. Mm-hmm.
Yeah. Yes. There is another way to put progesterone? No.
It's, there are things
by
like
the skin, no.
But the best way is a pill.
Yeah, already.
Absorbed better.
Okay. So let's talk about addressing the non-hormonal options that we have, botanicals, phytoestrogens, maybe. What the studies shows at that point. Yeah.
Yeah, I would add that when I wrote the book, we do not have Veoza. Actually, Veoza is in the book. So we now also have non-hormonal therapy for hot flashes. And those are called neurokinin inhibitors.
Yeah.
So that's a very interesting class of prescription medications that I would advise people to look into.
Yeah, it's quite new.
Are not an option, right? Yeah, so very important. Botanicals and supplements and things like that. The evidence for efficacy is lower than generally with hormone therapy, but that's obvious, right? Any medication is engineered to give you a strong effect quickly. When we look at the power of plants, especially in vitamins, we need to look at long-term changes. So that needs to be part of your lifestyle. And there are some formulations that have been associated with a gentler menopause. And I think my top two would be phytoestrogens, like you mentioned, which are estrogenic compounds that are extracted from plants. Those have been shown to work for some women, especially for hot flashes and night sweats.
Yeah, with the soy? No.
Soy, yes, there are soy extracts predominantly, or red clover as well. That's more for like night sweats. And then another one that's actually approved in some European countries is called black cohosh, which is another herb that is used for relief of menopausal symptoms. I would also mention some therapies that are non-hormonal but have been shown to work. And one is cognitive behavioral therapy, where basically you work with a specialist to, in a way, modify your response to symptoms. So you're not addressing the hormones necessarily, but you can train yourself to not feel the hot flashes as strongly as you might, or not suffer from stress as much, So that is valuable, and it's been endorsed by professional societies as well, which is a big stamp of success. Another one is clinical hypnosis. I think is more difficult to find specialists that really treat menopause, but they're becoming more and more available as the need becomes clearer. So that also is endorsed, or at least not frowned upon by professional societies. And then obviously we have lifestyle. And lifestyle is so important, from diet, exercise, stress reduction, avoiding toxins. There are many things that we can all do on a daily basis to improve.
Maybe just tell us what are the good things, and we have to be careful of the inflammation of the body. So sugar is the big maybe issue on that.
Yes.
And what else, for example?
So refined carbohydrates are not helpful, because hormones are hormones. Insulin is a hormone. I think it's really important to keep glucose and insulin levels steady as we go through the transition. So refined carbohydrates, refined oils, processed food in general is out. That has to go. Whereas whole foods, especially of plant-based origin, become really helpful, because they are a wonderful source of antioxidants, of anti-inflammatory compounds, of other compounds that do support hormonal health. And it's also becoming better known that, we always talk about the microbiome, but there's one part of the microbiome is called the estrobolome that is very specifically involved in estrogen regulation and recycling through the body. And what keeps those good bacteria or microbes alive is plants. They really love plant-based foods that ferment well in the gut, like oligosaccharides, onions, right? Beets, all these vegetables and tubers that have a little bit of a sweet taste, but not quite. And those are very good for gut health, which is in turn also good for hormonal health.
And what you said, that surprised me. You said you have to be careful with weight loss in the way you're making it, because sometimes it can be worse because the hormonal fluctuation, they don't like if you lose weight in a bad way very suddenly.
You know, that, yes. I mean, yo-yo dieting, crash diets are never a good idea. It's much better to focus on muscle mass. I think all women, once you're starting in your 30s and 40s, it is important to make sure that you have a good muscle mass and bone density adequate and skeletal mass, because that preserves metabolic activity. And what happens in menopause is that because the estrogen source is changing from estradiol, which is made by the ovaries predominantly, to estrone, which is made mostly by burning fat. Right. So what happens in menopause is a lot of women notice that they're accumulating belly fat, which is very upsetting for many.
Yeah.
For aesthetical reasons. However, that's our body's way of preserving estrogen reserves.
Yeah.
So you don't want to interfere in a dramatic way against what your body's trying to do, because that's going to be your buffer against estrogen depletion. So I think, you know, a healthy diet, a good exercise routine that is not punitive, but more supportive. There's a friend of mine, Mary Claire Haver. She's a menopause specialist.
Oh, yes, it's her.
Was it Mary Claire?
Yeah. She was talking about ADHD, yesterday, but we were talking offline about her. And I was not remembering her name. Yeah.
So Mary Claire, who's a friend of mine, I love her so much. And she always says, strong over skinny.
Yeah.
In menopause especially. And I think that's such on point. We're all so conditioned to look a certain way. You know, you need to have this kind of shape, or you need to be thin, you need to be slender. No. We need to be strong, because that is the most important preventative measure that we have. We want to preserve bone mass. You know, a hip fracture is what sends most women downward. Right. So it's really important that we take good care of ourselves. I think as women, we should let go of these prefabricated notions of looking a certain way and really just feel that we're strong and capable. We're happy, you know, to be comfortable in our own skin.
Yeah.
And I think that's a really good idea. So we pick up those dumbbells and resistance bands and do a little training.
Yeah, that's it. Musculation now is becoming very trendy because of that, because we have this information and we know it stimulates the hormone system.
Yes, absolutely.
And it's quite new as well.
It is new. Until very recently, it was all cardio. It was all like sweat it out. And how about slow but steady burn that supports muscle growth and recovery, which is very important. And it turns out to also really be good for brain health.
Yeah, that's it. And it makes the bridge. Maybe we are ending with that, with the mindset. And you said it's super important. You just said it at the moment. But sometimes when we are going through menopause, the mindset is not good. So, you know, it's like a vicious system.
Yes.
I'd like to be happy, but I have no desire. I feel I don't feel well. I'm not sharp anymore. Give me the ancient me.
Yes.
And
I think, you know, menopause will happen, whether you want it or not. So we may as well embrace it and make the most out of it, right? The symptoms are not your destiny. There are remedies. There are things that we can all do to feel better. We do need to be proactive. You know, unfortunately, we are in this gray zone where things are becoming available and specialists are becoming more specialized, but it's hard to find them. right? So you need to be proactive. You need to advocate for yourself. You can't take no as an answer. You may want to read the books and go to your doctor and say, how do you feel about this? Because I'm not going to be in 5 minutes. I need to know what's better for me. So we're going to have to work with the system at this point where hopefully, my daughter will not have to because of all the work that we are doing. But right now we still do. We need to advocate for ourselves. But I think mindset is really, really important. If you think that something is going to hurt you or harm you, you're much more likely to feel bad or to have negative symptoms and negative effects. That's called the placebo or the nocebo effect, actually. Whereas if you think that, it's not a picnic, it's not perfect in any way, shape, or form. However, I can handle it and I will be better off once I'm through it. Now, let's just make sure that I have all the help that I need. And this is a very important time, I think, to talk about self-care. Because I don't know how you feel about it, but midlife is when most women are completely sandwiched between responsibilities. You have children who still need your help, or maybe they're young. My daughter is 10. She needs a lot of help. And I want to spend time with her, but that's a lot of work. We have older parents who are going to need our help. We have families, people that need our help. We have jobs where we need to perform just as well, even though we have a million responsibilities. So then what happens is that your time for you is basically nada. And that is not okay. Midlife is when I think all women should really make an effort to appreciate that self-care is not selfish. Self-care is important. You cannot pour from an empty cup. You need to take care of yourself as well. And that will be better for everybody else that you're taking care of at the same time. Really feel very strongly about this. We deserve to take care of ourselves as well.
It's so important to remind us that we have the superpower to do it. And there are solutions, as you said, many solutions. Maybe a little word, if you have to say something on ADHD. We didn't have time to talk about it. Your friend, the doctor, Mary, she's talking about that. Sometimes some women said it had unrevealed my ADHD. I don't understand why. I was between 40 and 50 and suddenly I felt lost, and maybe with COVID as well, people said that.
Oh, yes, absolutely.
I don't know if it has potential, the menopause, but I think there are studies showing that.
Oh, yes. And see, I think the thing about menopause is that menopause is almost like an activator. It kind of unmasks potential medical vulnerabilities. So if you have a predisposition to depression, but you've never been depressed in your life, you may experience the first episode of depression as you go through menopause. Same with panic attacks or anxiety. Same with brain fog. Let's say if your neurons have a hard time, your brain is not doing so great with memory, but you're still handling things just fine. When your brain is in a vulnerable position, you may feel more forgetfulness. And the same for ADHD. Attention, the parts of our brains that are important for sustained attention and focus and concentration are heavily regulated by estrogen. So a lot of women, as they go through menopause, what they basically may be experiencing is a reduction in attention span and the mental fatigue on top of that, which really feels like ADHD. So it may not be a clinical diagnosis of ADHD, but you certainly may feel like you have it. The same way that so many women feel like they have early onset dementia, right? But it's in fact menopause. So the point is, let's see what happens over time. If that goes away, it was menopause. It was not a diagnosis of ADHD. You may not need treatment for ADHD. If it persists, then maybe you were destined to have ADHD, or perhaps you had ADHD, but you were very high functioning. And now it just came through. It's been unmasked. So menopause is a little bit like that. It brings about risks and may turn the risks, or the risks may become medical concerns at that time. Does it make sense?
So important to say so. Thank you so much, Dr. Lisa Mosconi, for this very important podcast. I think it's probably, I did like 1,400 podcasts, and I think it's one of the most important for women because you are a pioneer. You have all the information. You know what the studies have been made or not, and what is going on that topic. And it's the half of humanity who will go through that. So I remind that your book, The Menopause, so thank you so much. And I remind that your book, The Menopause Brain, just released for the French version, published by Thierry Souccar Éditions. The name is a little different. It's Menopause. Thank you so much again. And I hope to talk to you maybe when you'll have new studies to reveal for the audience and for women. Thank you so much.
I would love to. Thank you so much for having me. And I do hope you feel better soon.
Yeah, thank you.
Check out the special guest of the week on Instagram at Metamorphosepodcast. If you like this podcast, promote it by giving it 5 stars on Apple Podcasts and subscribe to follow all the episodes for free.
Metamorphose. Awaken your consciousness.